all of you on this webinar, which is called The Employment of Autologous Dentin Graft in Maxillofacial Surgery and Implantology, which is hosted by Simplodent India and personally by Dr. Vivek Gaur and Anui Gaur, my big friends, which is organized by Lviv National Medical University and my own Facebook platform, which is called Vares Study Club, and which is supported by International Implant Foundation from Munich, Germany, and KometaBio company from the United States, and personally by Mr. Amit Binderman, who is the CEO of this company. So briefly about me, I was graduated from Lviv National Medical University in 1995. Then I had 5 years of postgraduate education in maxillofacial surgery. Then I became assistant professor. In 2002, I got my PhD degree. In 2005, I became associate professor of the department. And in 2010, I got the degree of Doctor of Medical Sciences. And in 2011, I became a professor, and in 2012, head of maxillofacial department of Lviv National Medical University in Ukraine. I am an official member of European faculty of International Association of Craniomaxillofacial Osteosynthesis, member of ICOI, and speaker and teacher of International Implant Foundation. I am the author and co-author of 290 publications and 15 patents of Ukraine. Member of editorial board of 3 native and 1 international journals. I work with dental implants since 2005, and I was engaged to corticobasal implantologist in 2011. So we have this streaming from Ukraine, from the city of Lviv, which is one of the most beautiful cities in Ukraine and ancient cities, and here it is located in the very western part of the map of Ukraine. This city is amazing at day, at night, at all seasons, and even when the weather is rainy or snowy. And before we will go on with our topic, I would like to announce a very important event, a teaching program, which is called Diploma of Immediate Loading, which is organized by Maharaj Vinayak Global University, Jaipur, India, in association with International Implant Foundation, Munich, Germany, and will take place in Jaipur Dental College. And this program will start, if the lockdown will finish, in July 2020. This is a really big opportunity for the students, residents, and young doctors to get knowledge about immediate implantation and loading from the very experienced European and native teachers, and I am proud to be among them. Honestly, there are few schools worldwide which are teaching corticobasal implantology on academic level. One of them is in Nice Sophia Antipolis University in France, headed by Professor Gerard Scortecci. And it looks like this program in Jaipur University will be the second one where we will have teaching of corticobasal implantology. During 5 modules of this program, the participants will cover a lot of topics, starting from bone physiology and function, prosthetic concepts, to maxillofacial applications of corticobasal implants, maintenance and troubleshooting, and there will be lift surgeries as well. But the most important that at the end of the program, participants will understand how to provide the patients from no teeth to fixed teeth just in 3 days, not in 3 months, not in 3 years, and so on. Thus, on behalf of International Implant Foundation, I would like to invite the residents, the young doctors, or even experienced doctors from India and other countries to participate in this unique course. Today's presentation consists of 2 parts. Theoretical, where we will speak briefly about autologous dentin graft and the protocol of its preparation, and practical part, where I will share plenty of clinical cases of my own and my team. And we will start with a well-known clinical fact that tooth extraction induces significant dimensional changes of the alveolar ridge up to 6 millimeters loss of width and 3 millimeters loss of height, within 3-6 months after extraction, and the resulting deformity can be a considerable obstacle to aesthetic, phonetic, and functional results. In order to prevent loss of alveolar ridge, it is indicated to immediately graft the extraction site from the point of view of conventional implantology, from the point of view of oral and maxillofacial surgery. And obviously, it is quite difficult for the young specialist or even for experienced doctor to choose a right substitution material of those present on the market, because nowadays many options exist. We have synthetic scaffolds such as hydroxyapatite, tricalcium phosphate, coral minerals. We have ceramic xenografts like Bios, the most popular, Cerabone. We have allogenic bone. We have autogenic bone, both cancellous and cortical, which is still considered as gold standard since it exhibits bioactive properties and is non-immunogenic and non-pathogenic in spite of the need for harvesting bone and possible morbidity resulting from it. And since 2000s, we have one more option, which is called autologous or autogenic dentin graft. And I expect this is not surprising for the listeners that dentin can serve as native bone grafting material. But if there are doctors who are hesitating, who are evaluating all pros and cons, I believe that they will change their minds in favor on dentin graft. From biological point of view, when we evaluate bone substitution materials, we pay attention on 4 well-known criteria. Biocompatibility: does the material trigger osteoclast? Is the material isolated by connective tissue, thick cementum, granulation? Is the material rejected completely? How much inflammation do we see? How much pain, and so on? Bioactivity: does the material work with the natural healing process, against it, or not affecting it? Is there communication between the material and site cellular matrix, or is it just a filler? The next is osteoconduction. Does the material provide a structural scaffold for tissue to form around? Does the material support vascularization? Does the material support tissue maturity over time or resorbs too slowly? And osteoinduction. And when we take a look on a comparative table of the most useful materials, we will see that only autologous graft match all above mentioned criteria. That means that if we are using dentin graft instead of other types of materials, we achieve very slow resorption. We can re-entry our grafted site after 2-3 months instead of 6 months, as with other materials. We will observe little, if any, inflammation and secondary resorption. And finally, we will get a big volume of newly formed bone. So, summarizing the unique properties of autologous dentin, we can conclude that dentin undergoes ankylosis instead of other materials, which goes osteointegration. And this ankylosis provides high stability during first and second phase of healing process. And objectively, we will observe fast healing of the socket. Dentin contains lots of growth factors and BMPs, bone morphogenetic proteins, which generate new bone, resulting in fast bone regeneration and faster time to implant placement. Dentin is bioactive. It attracts progenitor cells, which accelerate regeneration of new bone. Dentin contains tough hydroxyapatite, which provide long-term scaffold that support bone remodeling. Thus, there is no loss in side dimensions, both horizontal and vertical. And finally, dentin is autologous. That means very predictably accepted by the patient, causing less pain and low inflammation. Regarding ankylosis and histology investigations. In the experimental investigation of Professor Anderson, dentin blocks from human premolars extracted for orthodontic reasons were used as grafts for substitution of tibia defects in rabbits. And as you can see on these histological pictures, all dentin blocks healed with ankylosis in contact with bone without inflammatory reactions. In the cortical regions of the tibia, fusion of bone with dentin was seen in 86% of the dentin surface after 3 months and 98% after 6 months. In another investigation of Professor Binderman and colleagues from Israel, during preparation of a slot for implant insertion, a core of bone was taken from the grafted socket side, and the histology that you see revealed new bone integrated with grafted dentin, producing a bone-dentin interface and connectivity. And if we look on this histology sample with much bigger magnification, we will see how intimate is the contact between dentin and newly formed bone. The first approaches to using autologous tooth structure as a bone substitute date back to 1960s, when Marshall Urist from United States with his team discovered dentinal bone morphogenetic protein. Later, this research area was forgotten for nearly half a century until 2000, when Korean investigators and Professor Binderman from Tel Aviv University started to investigate unique properties of autologous dentin for optimal extraction site management before implants placement, and the idea of smart dentin grinder occurred. And this is the list of the most recent publications in highly impacted journals regarding the employment of autologous dentin graft from 2019, 2012. And you can see here very famous names as, for example, Daniel Cardaropoli from Italy, Ziv Mazor, Robert Horowitz from United States, Snezhana Pol from Croatia. That means that autologous dentin graft is a matter of interest of not only practitioners, but also scientists, university co-workers, and this is very important. So why autologous dentin is so attractive for the scientists? Firstly, it is well known that jaw bones, alveolar bone, and teeth develop from cells of the neural crest, and that many proteins are common to bone, dentin, and cementum. Please pay attention on the comparison of some important components in dentin and bone. Hydroxyapatite, the content in dentin, 70% in bone, 60%. Collagen, 25% in dentin, 30% in bone. Water, 5% in dentin, 10% in bone. The content of growth factors and BMPs, some in bone, but more than bone in dentin. When we grind the tooth, we get 3 types of graft in one. We have super xenograft from milled enamel. We have super cortical from milled dentin, containing a lot of BMPs and growth factors, and we have super cancellous from milled cement. The additional benefits of autologous dentin graft are as following. We have no secondary surgical site. We have highly predictability for the short and long term. This graft is typically cheaper than most grafts because you all know what is the price of Bios, for example, on the market. Autologous dentin is highly regarded by patients. There is no need for membrane in many socket graftings, and what is important, it handles very beautifully. In summary, it is estimated that 20 million teeth are extracted each year in the United States alone. 30% due to loss of periodontal support and mobility, and 10% are wisdom teeth, impacted teeth, and orthodontic related extractions. And I think you agree that similar situation we have in India, Ukraine, and a lot of European countries, regardless the level of economic state. In most instances, we dispose of these extracted teeth as biological waste, instead take advantage of the fantastic properties they possess. Me personally heard about autologous dentin graft technology for the first time in 2015, when I met Dr. Larry Sapochnikov. Here he is, from Israel, from Tel Aviv, who was co-author of this invention on the amazing party after basic implantology course in Nice University under supervision of Professor Skortechi. And this concept really attracted me because I don't like to use synthetic or xenogenic materials. In 2017, during World Meeting on Growth Factors in Antibes, France, I met the world famous osteologist, Professor Itzhak Binderman from Tel Aviv University, who was the inventor of autologous dentin graft technology, and his son, Amit Binderman, who is the CEO of KometaBio company from United States, the manufacturer of smart dentin graft device. Immediately after the meeting, we signed the international scientific collaboration agreement between KometaBio Incorporated and my department of my university. And this collaboration agreement recognized the Department of Maxillofacial Surgery as educational and scientific center of autologous dentin graft technology in Ukraine. In the framework of this collaboration, we got all necessary equipment for preparation of autologous dentin graft, available literature, and started to work very actively. On October 2019, owing to support of KometaBio company and its official dealer in Ukraine, Zubnet company, we organized an international seminar optimizing implant placement in challenging sites, from grafting options to surgical techniques, with two world-famous key speakers, Professor Itzhak Binderman from Tel Aviv University and Professor Robert Horowitz from New York University. And this seminar got very good feedbacks from the audience. Now, briefly about the protocol of preparation of autologous dentin graft. In general, this is a 7-8 minute process, which consists of 8 sequential steps. The extraction of teeth and the preparation of the particulate dentin are done in the same clinical session. The first step of this protocol is to remove all cavities, artificial materials, and debris from patients' extracted teeth using high-speed handpiece with carbide or diamond burr, so that only clean tooth remains. There is no need to decoronate the tooth or remove the enamel, although there is a publication from 2017 of Italian scientists that due to its high mineral density, big parts of enamel inhibits the proliferation of osteoblastic cells. The second step is drying the teeth well by air syringe. The third step is to fix the sterile grinding chamber on a motor, then to place the prepared teeth inside the chamber next to the blades, up to 4 teeth at a time. And the fourth step is configuring the grinding and sorting time. By pressing appropriate buttons, we can configure time of grinding and sorting. Usually it is 3 seconds and 10 seconds respectively, according to manufacturer's recommendations. If large particles are left in the grinding chamber, you can do this again. You can start button again to grind for another 3 seconds and to sort for another 10 seconds. And during this grinding process, the teeth particles will fall down into 2 drawers compartments, upper which contains particles of between 300 and 1200 microns, and bottom drawer containing particles smaller than 300 microns. Then we remove particulate from the drawer and transfer it to the special glass dish, and add dentin cleanser. This is the bottle with red cap, which is basic alcohol, to cover the particulate completely and leave for 5 minutes for sterilization and disinfection. Alcohol in this case was selected because it is effective in reducing bacteria via denaturation, but also evaporates rapidly, thus not leading to cytotoxicity as compared to other antimicrobials such as chlorhexidine, for example. After that, using a sterile gauze, we dehydrate the dentin cleanser solution, and we apply phosphate buffered saline to completely cover the particulate. We use the sterile metal instruments to mix the particulate and dehydrate using a new sterile gauze. Then we need to repeat this procedure with buffered saline in order to neutralize pH levels. And in 8 minutes, particulate dentin is ready for immediate grafting. What is important? If you have an excess of graft, or if you want to postpone grafting procedure, you can dry it according to the protocol. The protocol is described on the website of KometaBio company, and you can do bone substitution 1 week, 1 month, 1 year later after tooth extraction. The same situation is with storing of extracted tooth for future grafting. You can clean the tooth, you can dry it, you can put it to the patient in sterile container, and then the patient will come to you 1 month, 1 year after tooth extraction to take this tooth as a bone grafting material. Now we will move to the practical, so-called practical part of this presentation, where I will share with you my own experience and experience of my team with autologous dentin graft employment and its composition with platelet-rich fibrin in different clinical situations, in alveolar ridge preservation, in wisdom teeth, after wisdom teeth removal, after cysts removal, in trauma surgery, in two-stage implantation, and what is the most important for the listeners, in one-stage implantation and immediate loading protocol. We start with the case of the patient 22 years old with distal impaction of tooth 48. We remove the tooth. We prepare dentin graft and sort it. We put this substitution material inside the socket of extraction tooth, put some stitches.
Anuj, if we have lost the connection of Professor Jan Vares?
I'm just connecting with him. I'm just checking with him. Swaras lost the connection. He will just relog in. He's trying to relog in.
So we'll wait. We'll wait then.
Yeah. Jan Vares, sir, please unmute the mic.
Sir, unmute your mic. Unmute your mic. You're not audible.
Now it's okay?
Yeah,
Yes.
it's okay. Okay.
Now it's okay. So we will move on with our presentation. So this is how we clean the enamel and the tooth from the debris.
Sir, please share the screen. The presentation is not visible, sir. Please share.
Okay, sorry, just a moment.
Anuj, sir is already in the Zoom meeting. He just has to share his screen.
Yeah,
You just
yeah.
have to.
Now
Yes,
it's okay
yes.
or not?
Okay, okay.
Now you see okay?
Yes, sir, we can see.
Okay, so we clean the tooth with the diamond burr and we prepared once again a dentin graft. Then cleansing and buffering on the graft. And we put it inside the socket of extraction tooth, put some stitches, and look how nice is the bone structure just 2 months after grafting. And what is most important, that the surface, the distal surface of the second molar is not exposed. Another situation, patient 50 years old, vertical impaction of tooth 48. Here we have paradental cyst associated with this impacted tooth. So removal of tooth 48, preparation of autologous cleaning and preparation of autologous dentin graft. You see how big is the volume of graft we get just from one tooth. Then we prepared PRF clots according Joseph Chocroun technique from France. This is a well-known technique. All of you are acquainted with it. Then we substituted the defect with the mix or with composition of APRF and autologous dentin graft. We covered the graft with APRF membrane, put some stitches, and look the situation 1 month after surgery. What I want to emphasize again, you see how big volume of graft we get just from one extracted tooth. We have the volume 2 times bigger than the tooth per se. Another interesting case, patient 25 years old with horizontal impaction of tooth 38 and traumatic mandibular cyst in the frontal area. Here you can see this traumatic cyst. So what was the idea in this case? The idea was to combine 2 surgeries in one, to remove the wisdom tooth, to grind it, and to use this graft for substitution of the defect in the area of traumatic cyst. So we started with the removal of tooth 38. We prepared the autologous dentin graft. Then we removed the cyst. by the window in the cortical plate. Here you can see how sticky is the graft. It handles very beautifully. Then we substitute this defect with autologous dentin graft, put some stitches, and look what happened after 2 months. Amazing bone healing. The bone structure in the area of the defect is the same as the bone structure is in neighboring areas of the mandible. Another case, a very huge traumatic mandibular cyst, 3 centimeters in vertical and horizontal dimensions, but also the patient have impaction of 2 lower wisdom teeth, 238 and 248. So the idea in this situation was the same, to remove the wisdom tooth and to use this graft for substitution of this huge defect of the mandible. We started with removal of tooth 48 and preparation of autologous dentin graft. Then we prepared platelet-rich fibrin according to Shukrun technique. Then we started to do surgery with the cyst, decorticalization, creation of the window in vestibular plate. Then we removed all the content of the cyst. It was blood and pieces of connective tissue. Then we isolated the teeth, the roots of teeth which were projected into the cavity by APRF membrane. And then we substituted the defect with the composition of APRF and autologous dentin graft. Then we covered the defect with APRF membrane, put stitches, look at the control OPG 2 months after surgery. The cavity is partially filled by the newly formed bone, and look at the OPG 5 months after surgery. You see that the defect is completely substituted by the mix of autologous dentin graft and APRF, which now are in the transformation to the natural bone. Another situation, lady 50 years old, deep impaction of tooth 48, follicular cyst, which is associated with this tooth. The cyst is very big in size, 25 millimeters and 2 millimeters vertically and horizontally. We created a mucoperiosteal flap. We removed the cyst sac. Then we removed the tooth. We cut it onto 3 parts because it was very difficult to remove it because of deep impaction. Then we prepared autologous dentin graft. Again. In this case, instead of APRF, we use the technique of PRGF from BTI Institute in Spain. This is plasma-rich in growth factors, but the role and the mechanism of use is the same as with APRF. We prepared the mix of platelet-rich growth, plasma-rich in growth factors and autologous dentin graft. Then we put the membrane from PRGF to cover inferior alveolar nerve, which was on the bottom of this cavity. We substituted the defect with autologous dentin graft and PRGF composition, covered the graft with PRGF membrane, like you can see on this picture. Put some stitches and look at the control OPG 2 months after surgery. We have partial substitution of the defect. And look at the OPG 5 months after surgery. You see that the bone structure in the area of this huge defect is completely similar to the bone structure in neighboring areas. Another interesting clinical case, which was presented 2 years ago in Krakow, together with my friend from Germany, Dr. Manuel Wildmeyer. A patient, 25 years old, with mesial impaction of tooth 38, but also the patient have traumatic mandibular angular fracture. Here you can see the fracture gap, the fracture line. So the idea was in this case to remove this tooth, to grind it, and to put it back for promotion of bone healing, first of all in the area of fracture, and also to cover the exposed surface of the second molar. So we started with opening of the fracture site. We removed the tooth 38 from the fracture gap. We prepared autologous dentin graft. Here you can see again how sticky and how easy handling is this autologous graft. We put the graft into the socket. And then we fix the fracture with titanium mini plate according to Champy technique in the area of external oblique line of the mandible. We put stitches. And here you can see very well the situation 1 day after surgery. The fracture line is still visible. And you can see the X-ray 3 weeks after surgery. The fracture line is not visible. And what is the most important, that the naked surface of the second molar is completely protected by newly formed bone, and there will be no risk of any periopathology in this area. Now, some words about autologous dentin graft and two-stage implantation. This lady, 30 years old, has periodontitis of tooth 36, and she has also impaction of tooth 28. So the idea was as following: to remove the tooth 28 and to use this graft from the tooth 28 to fill the defect in the area of removed 36, simultaneously with two-stage implantation. So we started with removal of upper wisdom, cleaning it, preparation of autologous dentin graft. The next step is removal of tooth 36 very accurately. Then we place the implant. In this situation, it was any one implant from a Megagen company. And then we use the autologous dentin graft from upper molar to fill the cavities and the defect around the implant and in the area of removed lower molar. This is the state of the gums 2 months after surgery, and this is the fragment of OPG 2 months after surgery. You can see how nice is the bone formation around the implant. The implant is well integrated. This is 2 months after surgery, and we finished this case with a zirconia crown, and the patient was very happy. This situation is more difficult. A young lady, 36 years old, periodontitis of teeth 35, 34, 36. What is good in this situation, that the bone peaks are on the normal level. That means we expect a good result of bone grafting. For sure, all these teeth must be removed. One tooth is with endodontic treatment, so we dispose it. And 2 teeth are well, so we grind it and use as bone substitution material. We started with teeth removal. Then we prepared autologous dentin graft from 2 teeth. Then we prepared platelet-rich fibrin membranes and clots. Then we prepare a composition of autologous dentin graft and APRF. Here you can see how sticky is this product. And then we put 3 implants, some of them into extraction sockets, some of them into healed bone, and we covered and we filled all the extraction sites with autologous dentin graft and APRF composition. We covered all the graft with APRF membranes. We put stitches. And here you can see the control X-ray 3 months after surgery. You can see how many bone we achieved when we use autologous dentin graft in composition with platelet rich fibrin. The bone is, the newly formed bone is in the area of extraction site. The newly bone is on the top of the implant. So it was difficult for me to re-entry these implants because there was a very big volume of bone on the bottom of the implant. Then prosthetic steps. In this case, we used multi-unit abutments because the implants were situated very deep in the bone. And this is control OPG with permanent prosthetics. You see how nice the bone is in the area of grafting with autologous dentin graft. And the final chapter of our presentation is grafting in corticobasal implantation. You all know that in corticobasal implantation, in strategic implantation, we don't need grafting because we rely on natural physiological capabilities of the organism to rebuild the bone under immediate loading, under functional loading, so we don't use grafts at all. But sometimes if we use no grafting, we have unpredictable vertical and horizontal bone resorption, as you see on these pictures. So my approach for 2 years is, if possible, to use autologous dentin graft together with the protocol of immediate implantation and immediate loading. And now I will show you how some clinical cases, how it looks like. Very young lady, 25 years old. She fell from the bike and she has traumatic root fracture of tooth 21. Here you can see fragmentation of the root, so for sure this is a direct indication for tooth removal. But this is aesthetic area and the lady wants to have this tooth very fast, not to wait several months or years. So we started with tooth removal. You see that the buccal plate was also broken because of the accident. Absence of buccal plate. We inserted one stage compression screw implant. This is KOS from Ida Dental. You see that the big part of threads, it is completely out of bone, but it is not a problem for us. We prepared autologous dentin graft from this central incisor. We prepared APRF clots, and we did a mix, a composition of graft and clots. And we filled all the socket of extracted incisor with this composition. We put APRF membrane in criss-cross manner around the one-stage implant, put stitches, made impression. And here you can see provisional metal acrylic prosthetics just 5 days after surgery. And when this lady came to me 5 months after surgery, you can see how nice is the contour of soft tissues, of pink gums in the area of this provisional crown. And you can see on the X-ray how perfect is the bone formation around one-stage implant. So what we did, we just changed the metal acrylic crown onto metal ceramic. Here again, you can see how nice is the state of the gums. And this lady was very happy. Another situation, quite similar to the previous, patient 41 years old, horizontal root fracture of tooth 11. The tooth is with endodontic treatment. But we decided to use this tooth also as a graft material, taking into account that there are investigations that BMPs and growth factors are still alive, even if the tooth is dead. It means that the tooth is after endodontic treatment. And taking into account this fact that even if we will have no osteoinductive properties of the dentin, this dentin will have osteoconduction properties. So what we did, we removed the crown and we removed the root. There was also the fracture of the buccal plate in this area. We prepared autologous dentin graft and APRF composition. We immediately inserted one-stage compression screw implant, KOS. In this situation, also some threads were absolutely out of bone, but we don't care about this. We covered the defect with autologous dentin graft and platelet-rich fibrin, covered the graft with APRF membrane, put stitches, made impressions, and this is state of the gums 3 days after surgery. We fixed provisional metal acrylic crown. And here on this X-ray, you can see how nice is the bone formation around the implant in the area of grafting 5 months after surgery. And we fix metal ceramic and the patient is ready. Another situation, patient 38 years old, traumatic fracture of lateral and central incisors. Here you can see the situation. When we did CBCT, you can see that the central incisors are completely out of the socket due to dislocation, traumatic dislocation. So all upper incisors must be removed. For sure that we decided to use this generally healthy teeth for preparation of autologous dentin graft. Surgical steps, removal of all incisors, insertion of 2 KOS implants in the area of lateral incisors. Here you can see how big is the defect after removal and trauma in the area of upper incisors. We prepared autologous dentin graft together with PRF in composition. We substituted this defect with this composition. We covered the graft with APRF membrane. Suturing, impressions immediately in the dental chair, framework try-in 3 days after surgery, and fixation of provisional metal acrylic 4 days after surgery. And if you take a look on the OPG 5 months after surgery, you see how nice is the formation of the bone in the area of the defect, how nice is the integration of 2 one-stage implants. And this is the end of the story. Now we need just to change the metal acrylic onto metal ceramic. Another clinical case, patient 66-year-old, periodontitis of teeth 17, 15, 14. Here, as you can see on the CBCT, you will see that there is no bone between oral cavity and nasal cavity, between sinus. We have oroantral communication. We have inflammatory reaction of the sinus. So to think about immediate grafting and implantation, in this case, from the point of view of traditional 2-stage implantology, it's impossible. But it is possible from the point of view of corticobasal implantology. So what we did, we removed molars and premolars. We placed tuberopterygoid implant as a distal support. We placed 2 KOS implants in the area of premolars. Here you can see that we have very huge oroantral communication. We made the sinus division through this oroantral communication. We removed all the inflamed sinus mucosa. Then we prepared autologous dentin graft from molar and premolar. This is the graft, then cleansing and buffering of it, preparation of PRF clots according to Shukrun technique. And we substituted the defects around the implants and in the area of oroantral communication with autologous dentin graft. Then we closed the communication with APRF membrane, put stitches, made impressions. Just after 5 days, we put metal acrylic bridgework. And look how nice is the situation 6 months after surgery. We have perfect bone formation around the implants. We have closure and formation of newly bone in the area of oroantral communication. we have tuberopterygoid implant as a distal support. And here you can see how nice is the state of the gums in the area of this big surgery. We made impressions once again, and we've finished this case with metal ceramic bridgework. Another case, patient from United States, a young man, 38 years old, but you can see how difficult is the situation, very pneumatized maxillary sinuses, periapical inflammation in the area of tooth of central incisor. You see how neglected is the state of the hygiene and oral cavity in general. So for sure that all these teeth must be removed and substituted by the implants. This is the CBCT of the patient. Once again, you see how big is the sinus on the left and on the right, periapical inflammation around the central incisor. So we performed multiple teeth extraction. We removed all the teeth. We made very precise mechanical curettage of the bone. We inserted 8 implants, some of them into extraction sockets, some of them into the septa between sockets, and so on. And here you can see insertion of BCS implants in the area of the floor of the nose and bending of these implants to do it parallel to other implants. Then, taking into account that a lot of teeth were generally healthy without endodontic treatment, we prepared autologous dentin graft, and here you can see how big volume of graft we have when we grind 4 teeth. We prepared APRF cloths. We took also some cortical bone from the patient and milled it with this manual milling device. And this composition is a mix of PRF cloths, autologous cortical bone, and autologous dentin. And here you can see that we completely rebuilt the alveolar process with this composition, covered the graft with APRF membranes. And this is state of the gums 6 days after surgery. We have metal framework try-in. And 7 days after surgery, we already put metal to acrylic bridgework fixed on 8 implants. This is control OPG 3 months after surgery. You can see that all extraction sockets after multiple removal of upper teeth are completely healed. There is perfect integration of all the implants. And here, where we did not do grafting, you can see that the sockets of the incisors are still visible. Another situation, patient 45 years old, patient from Poland with general aggressive maxillary periodontitis. All the teeth are movable, all the teeth are fixed to each other with light curing composite. The patient don't want to preserve this teeth anymore. So the wish of the patient is to remove all the teeth and to put implants instead. This is the patient CBCT. Here you can see also how bad is the level of bone. In some areas we have no bone at all. A lot of periapical inflammation, a lot of marginal inflammation of the gums. So we performed multiple teeth removal. Here you can see how many teeth we removed. We prepared autologous dentin graft from 4 teeth. Then we prepared APRF cloths according to Shukrun technique, and we prepare so-called sticky bone. This is the composition of APRF and autologous dentin graft. And here on this picture, you can see how really sticky is this product, this sticky bone. We inserted 8 implants instead of 14 teeth that we removed. And my assistant created completely new alveolar process from the composition of APRF and autologous dentin graft. Here you can see how it looks like, then suturing, impressions. And this is state of the gums 6 days after surgery. And we already fixed the metal acrylic bridgework. And patient is rehabilitated just in 6 days. He is smiling, he is happy. And this is control OPG 3 months after surgery. You see that no one of the socket is visible. We have perfect integration of all the implants. Now we are waiting to change this metal acrylic bridgework onto metal ceramic. So in conclusions, we can say that dentin is an excellent bioactive graft, no doubt. For better results, I recommend to use platelet-rich fibrin and autologous dentin graft in composition. And as for me, autologous dentin graft is a great app in immediate implantation and loading protocol, which speeds up healing and positively affect functional and aesthetic outcomes. So, and this is a gift for my Indian guys. So, don't stop and move forward in your knowledge. Thank you for your kind attention. And this is the websites where you can find more information about autologous dentin graft, about immediate implantation and loading. And this is my email. If you have some questions, you can mail me. And this is my Facebook page by hashtag VSC, Vares Study Club. You can find me and join me on Facebook. Thank you, Vivek. Thank you, Anui. Thank you, Antonina. And I am waiting for your questions.
Thank you very much, Jan Vares, sir. Awesome presentation. Thank you very much. It was completely different. And you know, actually, it goes with the basic principle that soft tissue follows the hard tissue. Sir. It is not like anywhere you can put soft tissue and you can present cases. Soft tissue always follows the hard tissue. Thank you very much. Sir, now there is a Q&A section is there. Q&A section.
Okay.
There you have to log in and you have to answer it actually, sir.
Okay, but before this, we must close the presentation.
Yes, sir. Yes, sir. We did it yesterday, so just
Okay.
stop the share screen. Yeah, and we can do now.
Okay, we have the questions from Dr. Karuna Karan. Do we have to remove enamel and cementum? No, we don't need to remove enamel and cementum. Enamel will work as a scaffold for vascularization, for new bone formation, so it's need to preserve the enamel. Do you hear me okay?
Yes, sir, we hear you.
Another question, what suture material was used in this case? I use 4.0 non-resorbable Prolene or propylene. How to obtain APRF membrane? Dr. Shanjai. So this is a routine protocol. You can just visit APRF.com website from France, from Joseph Chukroun, and you will see all the videos and all the materials how to prepare APRF membrane. So it's not a secret nowadays. The question from Dr. Kanvat Nanda. What are the criteria of selection of tooth for graft? Root canal treated tooth or vital tooth? Or tooth with periapical abscesses? In all of my cases, I use only vital teeth. without endodontic treatment. If we have periapical abscess, we can just cut this area by the burr and to use other part of the tooth without any problems. The same question about endodontically treated teeth. There are techniques in Russia Federation, in Europe, that allow to use techniques of dentin grafting that allow to use endodontically treated teeth. But in my practice, I don't use. But if Dr. Amit Binderman from United States is listening us, so maybe the CEO of KometaBio company will tell us some new directions, because as far as I know, now they try to use endodontically treated teeth in the practice. If PRF necessary all time or not. As for me, PRF is necessary, but in some situations, for example, from religious issues or other problems, that the patients don't wish to give their blood for preparation of substitution material. So in this situations, we don't use APRF. But in my practice, I like to use this because all of you know that PRF promote healing not only of hard tissues, but also healing of soft tissues. It contains anti-inflammatory components, so it's very useful tool for healing of both hard tissues and soft tissues. And the question from Dr. Ranga Bhaskar. In case of endo-treated tooth using for RDG, should we remove GP and sealer along with the post-obturation, filling composite before grinding the tooth? As I told previously, we must remove all the filling materials. And if you want to use this tooth even after endodontic treatment, for sure that you can remove as much as you can the sealer and endodontic materials from the root, from the canal. The question of Priyanka Bansai, in the tooth that was root canal treated and had gutta percha, the same situation. If you can remove gutta percha from the root very precisely, mechanically, chemically, so without problems, then you can use this tooth after removal of gutta percha. The question from Dr. Gupta, the very foundation of our dear mentor EDC, strategic implantology, deals with patients with no bone, very predictable results. Is it very successful since more than 2 decades, and I am following with excellent results. Now this PRF and dentin graft looks cumbersome and time consuming, sometimes unpredictable. Please give criteria, indication for case selection of these grafts. One regards. Thank you, Dr. Gupta, for this big question. So for sure that me, as well as you, we are working in strategic implantology, and we are not care about grafting at all. And we have perfect results with functional loading and that's so on. But taking into account that usually during immediate implantation and loading, we have multiple extraction of teeth. So why not to use this teeth for additional tool for substitution of defects after teeth removal? So it's not against the concept of strategic implantology. It's like an additional tool you can use or you cannot use. This is your own solution. But from my point of view, if we have a lot of dentin, which is osteoinductive, which is osteoconductive, which is biocompatible, why not to use this dentin as a bone substitution material?
Professor Jan Vares, Sir,
Yes.
you don't have to answer all the questions because you may be running late for your schedule also. So if you are free, then you can answer all the questions. Otherwise, there is no need to answer all the questions. They can ask, they can WhatsApp you, they can mail you, whatever they feel like, because I know actually you have a very tight schedule, sir. So it is up to you. It is up to you, sir.
So I have some time, so we can answer. So it's not a problem.
Thank you very much, sir. Thank you.
So do you hear me, Vivek?
Yes, we do, sir.
So, but I can't now I can't answer live. Why not? So the question from Setu Rajan: how could the machine remove enamel and pulp from tooth structure? The machine do not remove enamel and pulp. So we use both enamel particles and pulp particles as well, and without separation of enamel from the dentin. The question from Muhammad Anisur Rahman: how to elaborate APRF membrane? So all the protocol of APRF preparation is on the website aprf.com. You can go there and you will see all the procedure, how it runs. About root canal treated tooth, we already spoke. Once again about root canal. Periapical infection, we already spoke. Pterygoid implants are sympledent. Yes, pterygoid implants are sympledent for sure. We can use or TPG Uno or TPG. Any failures about autologous dentin graft, anonymous attendee? In my practice, I had no any complication with this type of graft. About preparation, ADG preparation kit. So I don't understand the question very well, but if you are talking about the device and the components, so this is the motor. These are the sterile chambers in which we prepare dentin, and these are the bottles with cleanser and buffering saline. This is the set of the basic set for preparation of autologous dentin graft. Can we use ATG in infected socket? Yes, after a careful mechanical and chemical curettage of the socket. How we disinfect the extracted teeth? With basic alcohol, as I told in my presentation. How can we store the tooth if we need grafted after if we need grafting after 8 months? The question from G to John. So the protocol of storing is available on the www.KometaBio.com. So you can go to the website of manufacturer and you will see how to store the tooth. Endoscopically, endodontically treated. Gutta-percha, there was this question. Carriers must be removed for sure. Removing gutta-percha, we already spoke about this. Is the dentin, will the dentin resorb? Yes, it will, but the time of resorption is very, very slow, and this is very good for new bone formation. Sterilization of autologous dentin graft is described on the website of KometaBio. How to preserve the autologous dentin graft for future? The information is on KometaBio website. About gutta-percha, we already spoke. Are the grinders available in India? This question is not for me. This question is for KometaBio company and its dealer in India. As far as I know, they have dealer in India, and this dealer works very well. We don't need to remove the pulp completely or at all. Can we mix PRP with ADG? Yes, we can. I don't understand completely the questions from Alex about the difference in healing of lower jaw defects and upper jaw defects. In my cases, I used Autologous Dentin on both jaws, and we have excellent results both on upper jaw and lower jaw. The question from Benny Augustine. No, we don't need PRF always. So it's your choice or the choice of the patient. You can use Autologous Dentin Graft alone without PRF. For how long we can store the graft? Following the protocols, you can store how long you wish. 1 year, 2 years, 3 years, and doesn't matter. PRF and PRGF, which is better? The question from Galaxy. So in our department, we use, for several years, we use both techniques, and PRF from Joseph Shukroun and PRGF from Eduardo Onitua from Spain. We use them parallelly. I don't see very big difference in clinical aspects. So the bone healing and soft tissue healing is perfect with both techniques. The problem is that PRGF technique is a little bit more difficult in handling and more expensive than PRF. This is my solution. The question from Dr. Karuna Karan about KOS implants. Is there any significance? I don't understand the question, but yes, in all of my cases, I use mostly KOS implants. Usually I use KOS implants or KOS-B implants or KOS plastic or KOS-B with a bendable neck to make them parallel to other implants. The pulp and nerve tissue is removed by the chemicals. We don't need to remove the pulp. This is the question. This is the answer from Amit. Okay. Okay, so I'm happy that Amit Binderman is with us on this streaming. Is this material used in sinus grafting? The question from Sadun Al-Kabi. Yes, there are a lot of publications on KometaBio website about use of Autologous Dentin Graft in sinus grafting with very good results. How to obtain PRF membranes? This is on the website of PRF. Do you have long-term follow-up like 5-10 years? With implants, yes, with immediate loading and with immediate implantation, but with Autologous Dentin Graft, just 2 years when I started to work with this product. What is the size of the ADG? The size of the particles is from 300 microns to 1000 microns, which is the most suitable size for using in bone regeneration. A message from Vivek. Where you can get dentin grinder machine in India, you must find the dealer and you will find it. Is it available in India? Yes. The graft particles we obtain in the lower tray also can be used as filler. Yes, this is a very good question. Or if you want to increase the volume of graft, it not must be discharged. So you can use the small particles as well. Yes, this is the information about the dealers. Thank you, Amit. The dealer is Sark Healthcare, Mr. Sunil Sharma. Thank you for your presence here. Do we remove enamel? No, we don't remove enamel. How to sterilize the graft? The protocol is on the website of KometaBio company. Okay, Vivek.
Sir.
Yes. Can we finish?
Yes, sir.
So can we finish, Vivek?
We are stopping the recording.